Welcome to today's webinar titled Prevalence and Management of Enteral Nutrition Intolerance Beyond the ICU. My name is Bethany Hopkins. I'm a Medical Affairs Manager with Nestle Health Science Canada, and I'm pleased to be the moderator for today's session. Before we get started, I would like to go over a few items so you know how to participate in today's event. As you can see from the image on the right, we've taken a screenshot of the attendee interface control panel. You should see something that looks like this on your own computer desktop in the upper right corner. The first thing I want to draw your attention to are the audio options. If you've joined using your computer speaker system, which is default, and if you would prefer to join over the telephone, just select Telephone in the audio pane and the dial-in information will be displayed. Next, should you require technical assistance, please type your question into the question panel to the right of your screen and our Citrix representative will assist. You will use the same question panel to ask questions during the session. As a participant, your audio is on mute. However, you will have the opportunity to submit questions at any time during the presentation. I will be collecting all of the questions for Dr. Madill, who will address them at the very end of her presentation. In addition, I want to make note that there are two handouts for today's session. One contains the presentation slides, and the other is a certificate of attendance. The certificate is available as an interactive PDF document so that you may type your name on the certificate before printing. Lastly, I'd like to note that today's session is being recorded. Now, it is my pleasure to introduce our presenter, Dr. Janet Madill. Dr. Madill is an Associate Professor at Bristol University College, Western University in London. Prior to this, she was a transplant dietitian and research advisor for University Health Network and University of Toronto Transplant Program. Janet has led innovation in knowledge translation, and she is now able to provide the practical experience of the dietetic profession to her nutrition students at the university level. Throughout her career, Dr. Madill has provided inspiring leadership, mentorship of many dietitians and students, and has actively pursued research endeavors that have achieved global impact. Janet has presented and published both nationally and internationally and is a recipient of a number of research grants. As some of you may know, Janet is a passionate educator, and she's an advocate for nutrition as therapy and a true champion for the role of the dietitian in leading nutrition practice change. Today, Dr. Madill will be talking to us about enteral nutrition intolerance, which has been reported as one of the most common complications associated with tube feeding. Findings of a recent Canadian study will be shared, examining the prevalence of intolerance in patients and residents outside the ICU setting. In addition, insights related to the management of intolerance were uncovered, which may have important implications for your tube-fed patients. I will now turn over the floor to you, Dr. Madill.
Thank you very much, and welcome everyone. As Bethany had indicated, that we will be reviewing enteral nutrition intolerance in adult patients beyond the ICU. In terms of disclosure, my involvement was in data analysis and manuscript writing. Throughout this program, you have the opportunity to ponder some very important points, such as how common is enteral nutrition intolerance in your practice? Does ENI interfere with adequate delivery of nutrition to your patients or residents? Do your healthcare colleagues understand the signs and symptoms of ENI? As well, we want to look at that within the spectrum of hospital malnutrition. As a brief outline, I will review enteral nutrition intolerance and malnutrition. I will discuss our results that we had from the Canadian study investigating ENI, specifically reviewing prevalence, assessment, management, and then I will offer some conclusions and future directions. In terms of your involvement, we have some opportunities to be very interactive. So we would like to first ask you, would you agree enteral nutrition intolerance can affect outcomes such as patient quality of life, reduced nutrition delivery, and malnutrition? If you can take a moment now to vote yes or no. So we'll give everyone, so far we've had 100% in terms of our respondents. And yes, you are 100% correct that it does affect Sorry, I'm just having a few technical problems to move on in terms of our, perfect, thank you. So 99% agreed that yes, and only 1% said no. And in terms of that, so that's wonderful, and you are in fact correct. Enteral nutrition, as we know, is an integral part of management of patients with functional GI tracts who are unable to consume PO. Enteral nutrition intolerance interferes with successful delivery of enteral nutrition and has a significant impact on patients, caregivers, and healthcare resources. E&I can manifest itself in many ways, such as nausea, vomiting, reflux, feeling of fullness, abdominal bloating or distension, diarrhea, and constipation. What are the manifestations? Okay, sorry, So what are the manifestations in terms of enteral nutrition intolerance? We know that enteral nutrition may be interrupted and or the total volume is decreased. Thus, that leads to complications of decrease in quality of life and thus a decrease in enteral nutrition volume. This will then have a significant impact in malnutrition. A significant amount of research has examined enteral nutrition intolerance in the critically ill population, i.e. the ICU. However, less well studied is E&I outside the ICU. So one question is hospital malnutrition a problem? Absolutely. If we look at Dr. Allard's recent publication from the Canadian Malnutrition Task Force, this was a prospective cohort study conducted in 18 Canadian hospitals, evaluating approximately 1,000 patients. And malnutrition was based on subjective global assessment, which is the gold standard. And they reported that 45% of patients on admission were malnourished. They also reported malnutrition was independently associated with an increase in length of stay. They also reported other nutrition-related factors associated with increased LOS, were a decrease in hand grip strength at admission, indicating low muscle strength, as well as those patients receiving nutrition support, which would be our TPN and our tube feeding patients, as well as those patients who consumed only less than 50% of food from their trays. In terms of implications of malnutrition, as we discussed, 45% of patients admitted in Canada to a hospital are malnourished. Malnutrition can lead to increased mortality, increased treatment, and increased length of stay. All of that together can decrease the quality of life of our patients, as well as increase the cost. It has been estimated that it cost is somewhere around an increase of 24%. In terms of survival rates, this graph clearly demonstrates a greater than fourfold increase of survival in those patients who are well nourished compared to those patients who are malnourished. Other studies that have been published was by Gunga Bassoon in May of 2015. This was a large study involving 167 ICUs. Data was collected on nutrition adequacy, ventilator-free days, ICU stay, and 60-day mortality. And this was approximately 2,000 patients. Incidence of intolerance was 30.5%, and this increase was associated with worse nutrition adequacy, indicating that patients were not meeting their protein and kcal needs. Those patients who had enteral nutrition intolerance were longer on the ventilator, so 11 days versus 2.5 days. As well, they had a longer length of stay, so 14 days versus 11. And there was increased mortality, 30% versus 62%. So let's talk a little bit about what the cost of that is. So if we look at the cost, we're going to do the math here. And I use $1,500 a day for a hospital bed, and that's probably underestimating the cost, but let's just use $1,500 as an acceptable amount. We know that if it's a 40-bed unit, approximately 50% of those patients in those beds are malnourished, so we have about 20 patients. If we know from the Canadian data that there's an increased length of stay by about 3 days, so that would mean $1,500 times 3 is $4,500 times 20 patients is $90,000. So what is that equivalent to? 1 RD salary. So what? The big so what? Previous research has not addressed the issue of enteral nutrition intolerance outside the ICU. Moreover, research has not fully considered what impact E&I will have on nutrition delivery and quality of life, and the implications for patients, caregivers, and healthcare resources. So in terms of our study, we have set up a manuscript, Prevalence and Management of Enteral Nutrition, and this is based on our objective, which was to investigate the prevalence and management of E&I in the non-ICU setting in Canada in adults. In terms of our methodology, this was a cross-sectional exploratory study using a quantitative online survey for dietitians across Canada. Information was obtained regarding tube feeding intolerance. Participants were emailed a link to an anonymous informed consent and survey, and data was collected from May to July in 2013. The participants were dietitians working outside the ICU, so dietitians who were in acute care facilities, long-term care, and home care. It was a convenient sample, and the inclusion criteria were dietitians who were practicing for greater than 5 years and consulting on at least 3 to 5 enteral patients per month. In relation to the questionnaire, this was a 38-item survey tool based on relevant literature and EN practice, and this was created from consultants from the marketing agency and representatives from Nestle Health Science, which composes the dietitians. And although the survey tool was not validated or tested for reliability, prior to dissemination, it was reviewed and edited by dietitians and medical nutrition industry professionals with expertise, knowledge, and insights regarding enteral practice. Therefore, in terms of this consensus building, this will improve content validity and reliability. The first 8 questions were pertaining to demographic information, and the next 28 questions were a combination of open-ended, multiple choice, in an effort to describe the patients who were receiving enteral nutrition, what were their feeding regimes, what was the prevalence of intolerant symptoms, focusing on diarrhea, high gastric residual volume, nausea, vomiting, feeling of fullness, etc. And then they were asked in terms of the preceding 3 months about the enteral nutrition patients they cared for. They were also inquired in terms of enteral nutrition symptoms, how they were assessed and managed. We have provided some sample questions, such as thinking about the patients you saw in the past 3 months who receive enteral tube feeding, what was their primary medical condition? How would you usually treat? And then we would insert diarrhea, nausea, vomiting, a symptom. And another question, what is the threshold for patients with high gastric residual volume? In terms of statistical analysis, we used a variety of statistics, and we defined significance as p less than 0.05. So what exactly did we find? first, we had 488 dietitians who met the inclusion criteria. 240 completed the survey, which is a survey of about 50%. So this is a very healthy response rate. Those of you who are involved in survey development, usually we see only about 30%. So this is very good that we have 50%. We had 100 dietitians from an acute care institutions across Canada, 80 long-term, and 60 home care. And most importantly, we have information on approximately 5,000 enteral patients who were managed in the preceding 3 months. So this is a very robust sample size. So in terms of demographics, what do we see? This is a busy slide, so I'm going to summarize on the side. Primarily, the dietitians were female, not surprising, practicing between 5 to 10 years, and managing about 10 to 19 enteral patients per month. In terms of the primary medical condition, summarizing, in the acute care, approximately 43% of the patients were post-stroke and other neurological conditions. In terms of home care, approximately 40% of the patients had head and neck and or GI cancer, with another 19 with other neurological conditions. In terms of long-term care, 48% of the patients were post-stroke and other neurological problems. So how about prevalence? The reported prevalence of greater than or equal to 1 GI symptom, we can see there were prevalence rates anywhere between 35 to 66%, with the highest prevalence seen in home care and the smallest in long-term care. So again, we'd like to take a moment for interaction. In your practice setting, are these prevalence rates similar? So if you could take a moment to vote. Okay, so it seems as though the voting is confirmed. So if we could show the answers. So 70% said yes, and about 30% of you said no. So we're going to continue on. In terms of symptom assessment, who is actually doing the assessment? So from this slide, you can see that the dietitians reported that 31% of the time they relied on the nursing or other healthcare professionals to determine gastric residual volumes. And if you look at the bottom of that, you can see that 47% of the time, the dietitians relied on the nursing and other healthcare professionals to assess the relationship or to assess diarrhea within our patients. And we're going to come back to those two issues later on because I think they're very important for us as clinicians to reevaluate that. As well, we saw 52% and 50% of the time nurses were reporting vomiting and nausea. We have another polling question for you. What is the most common intolerant symptom experienced by your patient? So choose one. So you have from A to E. I'll give you a few moments to answer that. Okay, so let's show the results of the polling. Interesting that diarrhea was the highest, followed by feeling of fullness, bloating, and abdominal distension, followed by nausea and vomiting, and then reflux and constipation as others. So we'll close the polling on that, and then we'll go back to our results. And we're looking at comparison of prevalence of E&I across healthcare settings. As you can see from this table, there was anywhere between 15 to 27% of the time patients experienced diarrhea, as well as between 13 to 23% of the time patients experienced constipation. As well, if you look at home care, their results were a little bit different than what the majority of the other institutions had, and that was likely because of the upper GI symptoms such as reflux, feeling of fullness, nausea, and bloating. Because if you remember back to our data, that there were a number of patients in home care who had head and neck and GI cancer, which is likely pushing those levels a bit higher than the other two institutions. In terms of management of symptoms, this is a very important slide that I think I want to spend a few minutes on. If we look at this, we look at medication as a strategy to manage GI symptoms, reducing tube feeding volumes, changing to different formulas, and switching to parenteral nutrition. If we look at this, we can see in terms of reducing the tube feeding volume that anywhere between 28 to 57% of the time, the tube feeding volume was decreased to manage GI symptoms. Following that was the use of medication, which was between 18 to 51% of the time. We know as dietitian clinicians, reducing tube feeding volume means that our patients are not going to be meeting their protein and caloric requirements, further exacerbating malnutrition. It is comforting to know, if you look at the orange bars on these GI symptoms, that very infrequently was TPN an option. Okay, so it's your turn, another interactive moment. In your facility, and I'm choosing diarrhea here, the most common reported strategy utilized to manage diarrhea is, and you have some options there to choose from. So go ahead and vote. All right, so we'll close the poll and show the results. So in your facility, what did we see? We saw that very similar results to what we found with our study. 42% changed the formula, followed by medication, and reducing the, 42% was changing the formula, 31% using medication, and 24% were reducing the volume. Very interesting results. So we're going to close that and move on. In terms of enteral access, what did we find from our study? Gastric access enteral devices were the most common. So nasogastric or G tubes were 83% of the time, and only 17% of the time was a nasojejunal or a G tube access used. In acute care, 56% were NG, and they tended to be most common. And in terms of continuous 24-hour feeds, that was very high in the acute care, likely because these patients are not long-term. In terms of home care and long-term care, results were a little bit different. Although we have bolus feedings, I'd like to refer to that as intermittent feeding, and they tended to be more common. So G-tubes, intermittent feeding in home care was 64%, and in long-term care was 52%, likely because of the nature of the patients within those different healthcare settings and they're being more ambulatory. In terms of our discussion, we found enteral nutrition intolerance prevalence to be between 35 to 66% in the different healthcare facilities. These results were very similar to other studies that have been reported in the literature. And most recently, Wang in 2016 reported enteral nutrition intolerance, in 33% of tube-fed patients. That is one of the only studies that looked at both ICU and non-ICU patients. Similarly, when considering reports of individual GI symptoms such as nausea, vomiting, and diarrhea, a recent report indicated a prevalence anywhere between 26 to 66% of the time, confirming that enteral nutrition intolerance is a common problem across these three healthcare settings and is occurring outside of the ICU. So in terms of evidence from our results and from the literature, this is the Wang study that I reported previously in 2016. This was an Australian study that reviewed patients' records for 12 months and pulled anyone's file that was on a tube feeding. They found that enteral nutrition intolerance overall was about 33%. They had a fairly large patient number, 754 patients, 60% in the ICU and 40% in the ward. Those patients who experienced enteral nutrition intolerance were less likely to reach their feeding goal rate. They found that management of ENI was highly variable between patients and between the ICU and outside the ICU. They reported that overall, medication was a common treatment for ENI, and then reducing feeding rate was the next common treatment. In relation to diarrhea, we report anywhere between 15 to 27% prevalence of diarrhea in our patients adult patients across Canada. This is similar to what is again found in the literature and appears to be within the limits of what is reported. So diarrhea in the literature has been recorded as anywhere between 11 to 95%. And Wang in 2016 reported, however, only a 5% incidence of diarrhea. One of the most important aspects of all of this is that negative outcomes, including decrease in enteral nutrition delivery, will lead to patients' decrease in their quality of life and further exacerbate malnutrition. In the latest issue of JPEN 2016, there is a fabulous tutorial which I would highly recommend that you review. This is a tutorial on management of diarrhea in critically ill patients. Their literature review revealed the prevalence of diarrhea to be anywhere between 2 and 68%. They also indicated that from the literature, the prevalence of diarrhea within ICU settings can be as high as 95%. The authors discussed possible reasons for this huge range is the definition of diarrhea, which should be greater than or equal to 3 unformed stools daily. They also reported that the information they found in relation to management of diarrhea was vague and subjected to different interpretations. And if you remember back to the data that we collected, that almost 50% of the diarrhea assessment was done by nursing staff, which is very important, and we'll come back to that again. These authors also indicated that the Bristol stool scale may not be the most appropriate for an ICU setting. The reason that they indicated was that this was tested on healthy volunteers eating a normal diet, and this was not best for sick individuals who were hospitalized, taking medications, and on enteral tube feeding. So talking about enteral nutrition intolerance, it would be remiss not to show stools, and so what I'd like to do now is review the Bristol stool chart. I'm sure we're all familiar with this. This is indicating there are different types of stooling, so anywhere from type 1 to type 7. And type 7 is the watery, no solid pieces, entirely liquid, and that should be used as a definition of diarrhea. So we also need to look not only at the consistency, but also the frequency of diarrhea. In terms of assessment, what we want to talk about is who should actually be assessing And I don't think we would all disagree with these authors that the dietitian is the key resource in enteral nutrition formula selection, method of administration, monitoring, troubleshooting enteral nutrition-related complications. In terms of managing ENI, from the literature, it has been reported that various strategies to manage ENI include using medications, reducing volumes or holding feed, changing the type of enteral nutrition, and switching to TPN. Enteral nutrition intolerance is reported as a common reason for interrupting enteral nutrition, and that ultimately leads to the amount of nutrition delivered. From our study, we found that dietitians reported that decreasing enteral nutrition volume was one of the most common practices, followed by medication use. In terms of weighing, they reported that 50% of the time there was a decrease in formula delivery, followed by medications. The most important aspect of all of this is that all in all, when we decrease enteral nutrition volume, this exacerbates the already too high malnutrition rates that are reported from the Canadian Malnutrition Task Force. In terms of formula selection, 80% of our respondents indicated that they used a variety of polymeric formulas. For instance, formulas with and without fiber were helped to manage patients with diarrhea or constipation. Formulas with different caloric concentrations were used to help manage volume intolerance and upper GI symptoms. And as we know, this is consistent with what is seen in the literature and with troubleshooting guidelines. 20% of the respondents indicated that they used peptide-based formulas to manage enteral nutrition intolerance. And from the literature, we know that peptide-based formulas have been suggested to help manage persistent diarrhea, help achieve prescribed feeding volumes, and that's the PEP-UP protocol from Highland, as well as from our pediatric colleagues, and this is the only time we deviate and talk a little bit about the pediatric population, that switching to a peptide-based formula managed upper GI intolerance, particularly in relation to gagging and vomiting. If we look at an algorithm in terms of management of diarrhea, I want to spend a few minutes on this. This is from that same tutorial published in JPA in September of 2016. And they looked at a possible algorithm for managing diarrhea within the critical care in the ICU. If you look at this, we're looking at stool output type 7. If you remember from the Bristol stool chart, type 7 is watery stool, completely liquid. And they were saying that 3 times within a 48-hour period. Then the next thing you would do would be to search for medication-related diarrhea, bowel ischemia, C. diff. We also added in there inflammatory bowel disease. If the diarrhea was in fact related to that, then a specific treatment would have been permitted. And then if you look at none of those problems being the cause for diarrhea, then the next part of this algorithm is to check the enteral feeding composition. So you're looking at either fiber-free or fiber-based. You may need to switch from high fiber to low fiber. And their suggestion was consider alternating fiber-based and fiber-free to achieve adequate fiber intake. If the patient persists with diarrhea, then you should consider a peptide feeding. They also indicated for stable patients, consider intermittent and bolus, and they use those terms interchangeably. So we will refer to them, consider intermittent feedings every 4 to 6 hours. And remember, this is just a template that we can possibly use for helping the nurses when they're assessing diarrhea within the patients. As well, we want to look at more of a good comprehensive approach to managing diarrhea. and that we will likely find that each institution, based on their own patient profiles, will likely have their own specific algorithm. So the purpose of presenting this to you today is so that we have a bit of a working knowledge of a possible algorithm that we can look at in terms of managing diarrhea in patients outside the ICU. These authors also offered some very key important messages in relation to managing critically ill patients with respect to diarrhea. I believe that we would all agree it's important to have a diarrhea definition for your unit, particularly if we know that 31% of the time nurses are defining and assessing diarrhea. Check the type of feed given and the amount of fiber delivery daily. You may need to reduce that. Consider different types of feeds and alternating feeds in your feeding plan to achieve the nutrition targets. Polymeric feeds are not always the answer. Peptide feeds with a higher MCT content might be of benefit to the patient, and intermittent feeding may improve nutrient delivery and might reduce the frequency of bowel motions. So again, another interactive moment. Would you agree that we need key messages for the management of diarrhea outside the ICU? So take a moment to vote yes or no. Okay, so let's close the poll and post our results. So it seems like 98% of you agree that we do need key messages for management of diarrhea outside the ICU, and I agree 100%. And so we can close the poll. I also wanted to take this time to talk about gastric residual volumes. The new Canadian guidelines indicate that between 250 ml and 500 ml is an acceptable threshold. There has been significant discussion amongst clinicians as well as in the literature in terms of should we continue to measure gastric residual volumes. If we look at the Canadian Clinical Practice Guidelines, their recommendation based on studies is that a gastric residual volume of either 250 or 500 ml or somewhere in between, and frequency of checking residuals either Q4 or Q8 hours should be considered as a strategy to optimize delivery of enteral nutrition in critically ill patients. However, we also know that there is no evidence for the use of GRV outside the ICU, due to the fact that there is minimal research looking at using and utilizing gastric residual volume in patients outside the ICU. Hopefully, we can put together a working group to help provide some research on this. And as with any study, there are always limitations. Some of the limitations from our study was that this was a retrospective design. Participants were asked to recall events for the preceding 3 months, so there is the potential recall bias. The questionnaire was reviewed and edited by professionals. It's not validated or tested for reliability, but remember, we had a consensus on the questions, which will increase the strength of the study both in reliability and validity. There is a convenient sample was used to recruit, so that's going to result in a sampling bias. However, it was a large sample size. We had well over 5,000 patients. It is Canadian data. It has been vetted by dietitians and management personnel working in the field, and we believe that a significant amount of novel information has been collected. So this is really the first step in providing some new research on enteral nutrition intolerance outside the ICU. So I can now offer some conclusions. Enteral nutrition intolerance appears to be common among tube-fed patients in a variety of different settings, with negative implications for nutrition delivery, further exacerbating that already too high malnutrition risk and the patient's quality of life. Further research is recommended to help validate our findings and to develop clinical practice guidelines to manage ENI, particularly given the recent interest in the prevalence of malnutrition across Canada. Evidence suggests that development of a Canadian clinical practice guideline is to manage ENI is vitally important, and work is in process. So currently, we're working with Bethany Hopkins and her colleagues to develop guidelines. Hopefully, we can pull together a group of dietitians from across Canada to help us achieve these goals and to provide Canadian guidelines for the management of ENI in patients outside the ICU. We now have two final polling questions for you. The first one, do you have tools and resources such as algorithms, education materials to manage ENI in your practice areas? Yes or no? So we'll take a moment to answer that, and then we'll come back to the second question. Okay, so we've got a fairly good response. If you could post the results. So do you have tools and resources? So 53% of us are saying that we don't have tools and resources, and 47% indicated yes. So those of you who indicated yes, we will certainly be contacting you and finding out which resources and algorithms you're using to help us come up with our Canadian guidelines for managing ENI in patients outside the ICU. If we could go back to the slide and do the poll for the second question. So would having tools and resources such as algorithms, education materials to help manage intolerance and create awareness among your healthcare team be of value in your practice? So again, please take a moment to vote yes or no. Okay, so it looks like we have a fairly good response rate. If you can close the poll and post the answers. So 98% of you agree that tools and resources would be helpful. So again, I think that kind of helps us streamline that dietitians from across Canada need to get together and to come up with these tools and resources. And we can work with our colleagues who indicated they have the tools and resources. So thank you for that, and we'll go back to our slide. So I would like to acknowledge Bethany Hopkins, dietitian, and Nestle Healthcare Canada team dietitians, as well as Mary Donnelly Vanderloo, who works in the ICU as a dietitian at London Health Sciences Centre, for their support and expertise in nutrition support. As well, I would like to thank all of you who participated in the study, and for those of you today who were involved in answering our polling questions. It's wonderful to have this collaborative profession that we're in. And with that, I will close and open the question and answer session. So thank you very much for your time today.
Thank you. Thank you very much, Dr. Madill. So as Janet has noted, we're now going to begin the question and answer portion of this segment. So I encourage all of you, if you have a question, to please send those in now and we'll go through them. And perhaps just before, well, this is still fresh in my mind, Dr. Madill, you made a comment when asking the question about if clinicians had, tools and resources that they were currently using to help manage intolerance, and we had a 47 response rate saying that, people had tools and resources they were using. And I guess I'll just throw this out there that if people have something that they would like to share that they find has been very useful in their practice, perhaps you could reach out directly to Dr. Madill with that information, and we can certainly help facilitate that as well if needed.
Yes,
okay.
I agree 100%.
Okay, so for questions, Janet, there are some questions and certainly some comments that have come through. One of the questions, the first question here, says, when you talk about reducing tube feeding volume as a management strategy, does that also take into account whether or not the formula was changed?
In terms of the literature, they spoke only in terms of decreasing the actual tube feeding, the volume, not necessarily changing the type. But if they were on a specific feeding, then that volume of that tube feeding was changed. Was decreased.
Mm-hmm. Okay. There's another interesting comment here, and this is it's around topping up enteral formulas. So they're saying sometimes, I find frequently, enteral formulas are topped up by nursing staff when open systems are being used. So the tube feeding is ordered by the dietitian as so many mils per hour, and that there sometimes remains a little bit of formula in the bag until the bag is changed, and then new formula, continues to be added. And the comment here is that, the concern is the risk of contamination in this situation is huge. I don't know if you have any additional comments to that, Janet, in terms of that practice of sort of continually topping tube feeding up in open systems.
Yes, I think that you're absolutely correct, that I think that we were always taught to hang the bag for 4 hours and not add additional formula to the bag, because it's true, there is an increased risk of infection when you do that. So I agree 100%, and I'm wondering if that is a practice in other institutions across Canada, but certainly I don't think they should be doing that.
Mm-hmm. Yeah, and this concept of a continuous culture, I think, can kind of happen in that open tube feeding system.
Mm-hmm.
A question here, this is specifically around formula choice, and just wondering, and I may be able to answer this for you, Janet, as well, but they're asking, is Resource 2.0 considered a peptide-based or a polymeric supplement? And I can answer that, and it's
Sure.
considered a polymeric. Now, one of the questions is relating to, do you break out the symptoms of intolerance between patients fed via G tubes versus J tubes? And you were involved in the initial setup for them, so perhaps you could answer that, Bethany? Okay, and it wasn't, patients weren't categorized whether they had a G tube or a J tube with respect to their intolerance symptoms, so we don't have the data analyzed to that level. Right. Well, we do know from the literature that nasojejunal feedings tend to be better tolerated than nasogastric, but that's basically what the literature is indicating. There's another question here, wondering about whether or not we need to lower the amount of fiber to help treat diarrhea in patients receiving enteral nutrition. I think that's a very good question, and I wish I could provide a very good answer, but I think if we go back to the algorithm from the Brito-Ashurst September issue of 2016, basically what they said was they talked about fiber-free and fiber-based, and that consider alternating fiber-based and fiber-free. So you might be doing a combination and going back and forth between more fiber and less fiber to help with treating diarrhea. And then they say that with persistent diarrhea, then consider the peptide feed. So I think it's a very good question, and I think that we also talked about having
a good comprehensive approach to managing diarrhea. So I think it's going to depend a lot on your patients and the types of patients that you're seeing. But certainly in terms of that algorithm, looking at managing diarrhea in critically ill patients, there is a lot of discussion about fiber, the amount of fiber in feeds. Whether there's too much fiber in the feed, the jury's still out with that. But certainly alternating between with fiber and without fiber to get the best outcomes would be certainly an approach that I would consider.
Okay, thank you. Yeah, a couple of questions came up about fiber, so I think that nicely answered both of them. There's just a question related to tools and resources. So there's a request whether or not it's going to be possible to, have some of these tools and resources shared with, a broader group of individuals, such as those that have joined us today.
That's a very good question. I think certainly we can have a discussion about that. I believe, Bethany, that you have emails from those who have signed up for this webinar?
Yes. Yeah, it's something that we can certainly take offline and see what would be the best way to sort of manage that in the future.
Right. And then also with that, perhaps as I had indicated, that I really believe that dietitians from across Canada, we need to be getting together and having a working group to talk about enteral nutrition intolerance and management strategies for our patients outside the ICU. Certainly, there is, as we talked about, a large amount of research managing ENI in the ICU. There's nothing wrong with looking at those algorithms and those management strategies and seeing how they can fit into patients outside the ICU. So certainly, I think that it's true that we need to share our resources as well as start to develop the guidelines for ENI outside the ICU.
A question here about medications. This person is wondering, what is the most common medication ordered to manage enteral nutrition intolerance? And secondly, if dietitians find they are making the recommendations or the physician.
Okay, so based on the literature, the two main medications that were most prominent were the use of prokinetics and the use of antiemetics. Those were the major two medications that were indicated in terms of the literature. Certainly, within the scope of the dietetic practice, we can't provide the medication, but we certainly, as part of the healthcare team and working with the healthcare practitioners, i.e. the physicians, to encourage them to provide prokinetics or antiemetics. And I think that dietitians within your own facility, you need to perhaps set up some kind of medical directive and or have good communication with your physician so that you aren't spending a lot of time. I remember as a clinician spending a lot of time trying to talk about enteral nutrition intolerance and, please stop turning the feed off. This is what we need to be doing. But also in terms of medication, there's, I think dietitians need to be much more proactive. And as part of the algorithm, maybe we can build into the algorithm that, prokinetics or antiemetics need to be used. But that certainly were the two main medications from the literature review that we conducted.
Thank you. There's another comment here, and this is something that I know I've seen in practice as well. So this individual is saying that they found pigtail catheter types of G-tubes often migrate down from the stomach, resulting in diarrhea. And so sending these individuals back to radiology to recheck the position of the tube provides a lot of help in terms of managing patients that present with these sort of dumping type of symptoms, and it would be because the tube has migrated. Right.
So that's a very important point. And as I said, that's working collaboratively with our colleagues across Canada, because there may be some institutions where that is a problem. And so we can have some guidelines and strategies in place to address all of those issues.
There's a question here with respect to methodology, and from the retrospective study, were the dietitians going back to review the charts to obtain objective data, or were they asked to recall from memory the frequency of intolerance?
Good question. So Bethany, you were part of the initial, do you know? I think they were asked to recall.
It was a recall survey, absolutely. So people were not going back and retrospectively looking at charts.
Yeah. So again, that would be a limitation of the study.
Yes.
However, that being said, if you're a dietitian working, say, in long-term care, and you have an idea that generally you're seeing 40 patients, and of those 40 patients, 25% of them on average have diarrhea or have nausea or have vomiting or whatever, it's probably not that far off. But yes, it is a limitation in terms of asking people to recall. But as I said, if you're a dietitian, and the majority of our dietitians had been working 5 to 10 years, we didn't ask if they were 5 to 10 years in that particular facility. But I think after a while, we'll have a fairly good idea in terms of the types of patients we have and the enteral nutrition intolerance symptoms that are occurring within our facility. So.
There's a question, Janet, about using open versus closed system, and sort of similar, sort of getting at a similar comment as the first question, and asking, did we look at the use of open versus closed systems for enteral feeding delivery? And this person said they believe the chance of contamination using an open system and intolerance, would be increased in those situations.
Yeah, I agree.
So it wasn't something that was, I don't think, particularly teased out in this particular data set, but that would be a really, I think, interesting follow-up point to look at some point, wouldn't it? Yeah.
Absolutely.
Another question here with respect to when talking about reducing the volume of feeding delivered, was there any distinction about reducing the rate but increasing the duration? So, for instance, delivering the same volume but just adjusting the rate.
Right. From what I understand from the questionnaire, and Bethany, you can add on to this if you want, that I don't think we looked at nor asked, nor I don't believe the dietitians reported that when they decreased the volume, did they then, instead of 12 hours, do 14 hours? I don't think we had that level of information that we asked from the dietitians. Is that correct?
Yes, and people were responding that they would either reduce the rate of the feeding, or in some cases the feeding would be stopped altogether for a period of time, and there was no indication of adjusting volumes or catching up feeding, although we can't exclude that as a possibility. It just wasn't mentioned in any of the open-ended answers.
Exactly, and I would suspect that if that was a common strategy that was utilized in home care or long-term care or in the acute care facilities, that they would have, after each question, there was time to comment. And I believe that if, in fact, the dietitian was doing that, or that was sort of the protocol for that institution, they would have made comments. And I don't remember when I went through the answers to the question, that there was any information that dietitian said, yes, we might decrease the enteral volume, but we would feed longer time, or we would do a top-up later on. I think that would possibly have come out, but certainly is a very valid point.
Yeah, I agree. And the data set, the survey was in 2013, and even practices with regards to volume-based feeding and topping up have evolved, in the past couple of years, even more so than they would have been, I think, at that time. Yeah.
Right. And then the other important part of that is if you look at the results from the Canadian Malnutrition Task Force, we know that approximately 45% of the patients when they were admitted to hospital were malnourished. But I believe that I read other studies as well as part of the CMTF was that 67% of the patients were leaving malnourished. And if you remember, one of those increased length of stay was patients on nutrition therapy, so enteral and TPN. So my theory and my thought is, for the most part, And again, that would depend on the institution. I know they looked at 18 hospitals across the country. It's likely that, in fact, we aren't, topping up the tube feeding, but it's hard to know.
Yeah, I would concur. Now, I just see that we're at our time, and we still have some additional questions. So what we will do is we will go back and we'll take a look at those questions and do our best to get back to you individually, those of you who posed questions. We do have your email addresses, so thank you. And before we sign off, I just want to thank you again, Dr. Madill, and thanks to all of you who attended our webinar today. You will receive a short survey, and we would appreciate your feedback. And you will also receive a follow-up email within the next week or so that will have a link if you would like to view the recording of today's webinar or share it with your colleagues. So on behalf of Nestle Health Science and our presenter, Dr. Janet Madill, thank you so much for joining us today, and have a wonderful rest of your day.